I was asked to look at some of the abstracts in lung cancer, and I just want to touch on 3 of the abstracts. One was on the role of bevacizumab in the treatment of mesothelioma. The treatment of mesothelioma since the year 2004, the standard treatment has developed its cisplatin, carboplatin, and pemetrexed. And since that time, so that since more than 11 years, no further advances have been made. So we all were expecting very much the results of a French study group, the IFCT, presented by Dr. Sackmann at this meeting, on the role of bevacizumab in the treatment of mesothelioma. And the French group could show that the addition of bevacizumab to the treatment of mesothelioma, the addition to bevacizumab to cisplatin and pemetrexed provides a survival benefit, a significant survival benefit with a median overall survival increased from 7.5 to 9.6 months. So I think they set up what could be a new standard for mesothelioma if the drug is approved in this area. Now, I think it's about 2 years ago, we heard the news that the PROCLAIM study was terminated early because of futility. And we all were interested, what went there, what went wrong? Now, the PROCLAIM study, which was presented by Suresh Sheenan at this meeting, looked at the role of the combination of cisplatin and pemetrexed together with radiotherapy in stage 3 non-small cell lung cancer. The aim of this study was to try to establish a new standard over what is commonly known combination of etoposide and cisplatin together with radiotherapy. Now, the trial was closed early, but just 5 points short of the estimated accrual needed, and we heard at this meeting that, unfortunately, the situation is this: cisplatin pemetrex given 3 times, followed by pemetrex maintenance for 4 times, is not superior to the old standard cisplatin etoposide given twice every 4 weeks during radiotherapy with 2 cycles of cisplatin etoposide as consolidation. Now, the question is, what will be the impact of this study? And I think the impact will be limited because the combination cisplatin pemetrex is already in the NCCI guidelines as one of the treatment you can give. Of course, it was not a non-inferiority study, but there was some difference in toxicity, and if you leave the cost issues aside, it looks like it will also be a valuable treatment. Another study was presented here, which was focusing on advanced squamous cell carcinoma patients, 2nd or 3rd line treatment, here in this case 2nd line treatment. Of course, we will hear about all the excitement with immune checkpoint inhibitors in lung cancer, but I want to touch on another study. Erlotinib has been registered for the use for 2nd or 3rd line treatment in patients with squamous cell lung cancer. The study was asking the question, is afatinib, which is a 2nd generation irreversible inhibitor, is it superior to erlotinib in this setting? Study included almost 800 patients, and it showed with a hazard ratio of 0.81 a superiority in overall survival of afatinib versus erlotinib with a median overall survival ranging from 7.9 for afatinib to 6.8 for erlotinib. So it was presented by Jean-Charles Soria, who clearly said, you know, in an ideal world, afatinib would be the new standard for the treatment of squamous cell lung cancer 2nd or 3rd line. However, it came clear also in the discussion session that, of course, with the advance in immune checkpoint inhibitors, there will be a question what the role is for any kind of tyrosine kinase inhibitor in this setting. Thanks.